Huh. Okay. So basically, very briefly, we know that when we talk about medication, medication is only at most 20% responsible for the treatment of the symptoms, because there are many other aspects of treatment of schizophrenia as well as depression, which I should actually mention every time, because people think I'm just only interested in medication, which is completely untrue. I know the limitations of medications, and I want to convey that to you too, because medication is just a part of the puzzle, one piece of puzzle. So basically, they're all psychotherapy strategies, and the rehabilitations, and social skills training has been very actually significantly important in schizophrenia research, where social skills training makes a big difference. Sometimes maybe even more than the medications, unless they are in acute psychotic episode. So with that, let me start. Um, there are many issues in psychiatry and treatment. Medication non-adherence is one of the biggest one, which actually is probably most significant in schizophrenia. Okay, let me see why. Okay, so so when you look at this, the patients who are hospitalized is reflected by the bars, the length of the bar, and the longest medication gap. So the longer the medication gap, the higher the rate of hospitalization. So that is we all know that. So I'm not going to spend a lot of time. Um, and just kind of give you an idea how many schizophrenia patients are taking their medications regularly. So only 50% are at about 45, no, 50% compliance in only 45% patients, right? So that's very low. So that tells you that, and there is actually a rule of third, that only 1/3 patients take their medications regularly, and only one third of them take a little bit of it, and only one third are never take their medication, or don't use their medications. And then you have this, let me go to, okay. So there are different classes of antipsychotic medications. As remember, we spent a lot of time when I was doing my psychopharm lectures and antidepressants. We actually have not as extensive classification. Actually, I believe we should have more as extensive as antidepressant. But conventionally, for your exams and for your test, I think you should only remember this classification. I'll mention what other classifications I would like to have, but they are not academically important, only kind of making your knowledge more solid about antipsychotics, then it will be helpful. So antipsychotics are broadly classified into conventional, or first generation, or atypical, or second generation. I like to use word second generation, because atypical is kind of creates misperception, because they are first line of treatment these days in many countries and many patients. So they should not be atypical. They should be there. I prefer second generation. So we'll refer to them as conventional and second generation. And the conventional are again subdivided into two classifications. One, conventionals, which are low potency antipsychotic medications, and the other one, high potency antipsychotic medications. The low potency conventionals are chlorpromazine, thioridazine, mesoridazine, and so forth. And the high potency are include different classifications. Phenothiazines, which is one of the most commonly used high potency antipsychotic medications, such as perfenazine, flufenazine, and thioxanthines. Thiothixine is not that frequently used, at least in America. And then butyrophenones, very popular old type of high potency antipsychotic, haloperidol. There is another sister compound of haloperidol, which is called droperidol, but that causes a lot of problems with QTC interval, so that's not used at any significant level at these days. So haloperidol is one of the most common, Fluphenazine is also very frequently used among the phenothiazines group. So let's move on. And the second generation antipsychotic medications are also known as serotonin dopamine blockers or antagonists, SDAs. Serotonin dopamine antagonists, right? And they include the model drug which started this atypical or second generation race was clozapine, and then followed by risperidone, olanzapine, quetiapine, ziprasidone, paliperidone, asenapine, lurasidone, and there is another one which actually has come recently. I don't have slides for those, but maybe in the next lecture, because a very interesting drug, we'll talk about that. Um, and then within the serotonin dopamine blockers or antagonists, there is another class as known as partial agonist. Although it is classified as atypical or second generation, but that's where I will tell you that this should be a completely different classification of antipsychotic, because they're completely different from conventional high potency or low potency, and also the serotonin dopamine antagonist. Okay. Now, this is a very important slide because I don't know whether I've shown to you these before, but this is a kind of sort of you really want to learn what is the relationship between dose response and adverse effect. This is the slide to remember. Okay. So basically, what I'm showing here is that on the x-axis, you have concentration of the drug in plasma, and on the y-axis, you have the percentage of patients responding. Okay. And so basically, it makes a lot of sense that as you start the antipsychotic drug or any drug for that matter, there is a therapeutic response window. And if you go higher than that, then you start to not enhance the response. But what happens is you start to elevate the adverse effects. So don't think that by increasing the dose, if the response is not increasing, there's nothing happening in the patient. No, completely wrong. If you keep on increasing the dose, the response actually will not improve, may actually decline. And I'll tell you the reason for that. But if you keep on increasing beyond the therapeutic window of an antipsychotic medication, you will start to have the adverse effects. So you see this close relationship between response, efficacy, and tolerability or adverse effects. Never forget that, because, I've been teaching for years now, and people don't connect these two things together. You cannot just work efficacy in a vacuum. Every time there is a change in dose, especially those beyond the therapeutic window for a specific medication, the patient has to pay the price for it. Easy for us to increase the dose or keep on doing it. Okay. So please remember that. So what is the, I think some of you might know what are the grounds for calling a antipsychotic medication as second generation or atypical, right? Now I didn't have time to explain to you that the conventional high potency medications, antipsychotic medications, primarily block the dopamine type 2 receptors, right? And they usually are, relatively speaking, they're specific in blocking the dopamine type 2 receptors, and they don't have any significant effect on the serotonin receptors, right? And that is a quality which the typical or the conventional or the older antipsychotic medications have, especially if we are talking about high potency, because low potency is a different ball and game. Low potency has multiple targets, and I don't want to confuse you, but we are talking about high potency. They are relatively more selective for the D2 receptor. Okay, just to give you an idea about the difference between the two major classifications. So what is the thing which differentiates the second generation antipsychotic medications from the first generation? I told you already in the previous slide that the second generation antipsychotic medications are also called serotonin dopamine antagonists, right? There you go. You already know what is the difference, right? So in addition to blocking the dopamine, they also block the serotonin receptor, right? So if you remember the name, you will remember their mechanism of action. Now, what is this big deal about blocking serotonin 5-HT2A, a subtype of serotonin receptor, along with the dopamine type 2 receptor? So I'll show you that. But before that, atypicality of a drug is determined by the ratio between 5-HT2A receptor occupancy slash D2 receptor occupancy. Okay. And please, if you have any questions, we can give some time at the end, although, it's a very long presentation. I'll try to be as quick as possible. Okay. So clozapine ratio is 100. What does that tell you? That tells you that clozapine has a very weak, relatively speaking, much higher affinity for the 5-HT2A receptor as compared to D2, right? Remember, that is the quality for an atypical antipsychotic or a second generation antipsychotic to qualify as a second generation, that they have higher affinity for the 5-HT2A, which is the serotonin 2A receptors, as opposed to D2 receptor. And clozapine is sitting at the top. Why? Because it has one of the biggest differences, right? That is the reason why clozapine almost never cause EPS, extrapyramidal symptoms. Why? Because it has such a low affinity for D2 receptors. You can give 900 milligram to a patient. Other side effects might kill the patient, but they are not going to have extrapyramidal symptoms because of the very weak and transient blockade of the D2 receptor by clozapine as opposed to D2. Clozapine for the D2 receptor as opposed to the other receptors. So D2 receptor is very transient occupancy and very weak. Risperidone, on the other hand, has more D2 affinity. And then you go down the list, you go to chlorpromazine, which is a low potency. So obviously that will be lower because as a matter of fact, higher, slightly more than risperidone, because it is conventional low potency, ziprasidone, and then so forth, olanzapine. So you see how the D2 blockade is becoming more occupant as you go down the list. You see that? So, and some of you might actually say that this does not make sense, that 5-HT2A is higher affinity as D2 because 100. So the one thing which I would like to explain to you is that the 5-HT2A, there are two measures for the affinity. One is the Ki values, and one is the Kd, the dissociation constant, right? So basically here you see that clozapine has much higher dissociation, 5-HT2A affinity than the D2 receptor. So let's move to the next slide. So basically this is a mnemonic I use for to talk about medications. So this mnemonic is STEPS, if you can remember it. S is for safety, T is for tolerability, E is for efficacy, P is for price, which is the cost of the medication, and S is for simplicity of administration, how simple it is to administer the drug, whether it's IV, IM, or oral. And this is a vicious cycle because you cannot separate any factor which is involved in the efficacy and tolerability and medication adherence of these patients, these medications. So I'm not going to invest a lot of time because safety. In terms of safety, we need to know the therapeutic indices of these medications. And we then also need to know therapeutic indices is basically acute. So it happens earlier, you want to know what is the acute therapeutic indices of these medications. And then long-term safety and drug interactions also are usually counted under safety. So the acute therapeutic indices of these medications, if you talk, there is a class difference, obviously. For example, the therapeutic indices of low potency conventional antipsychotic medication is much lower than the high potency conventionals. Why? Because the low potency conventionals have multiple targets, including anticholinergic effect, antihistaminic effect, alpha-1 blocking effects resulting in dizziness, partial hypotension, and so forth. They may actually, and also they have QTC prolongation effect, just like the tertiary amine tricyclic antidepressants, right? So they can result in acute, the torsades deponds, and can result in sudden cardiac death. To tell you frankly, some of the high potency drugs are also have effect on QTC, but not the other effects. Okay, so that's so basically, when you talk about the therapeutic indices of the atypical, with some exceptions, they are relatively better than the conventionals and the high potency. And we don't have time to go into detail, but generally speaking, so there are some exceptions there too. Long-term safety problem, because when you block these different type of receptors, they have long-term implication. For example, if you block H1 receptors, which is a characteristic of some of the second generation as well as the low potency conventional antipsychotic medications, then you can cause weight gain, right? And then D2 excessive D2 blockade can cause tardive dyskinesia, even neuroleptic malignant syndrome, and can have long-term effect on the cognitive functioning, and also may increase the negative symptoms at higher dosages, which sometimes mimic as depressive symptoms, right? So there are a lot of implications. And then don't forget about metabolic syndrome, which is the biggest problem in terms of long-term safety in these medications, especially those like clozapine and olanzapine, which actually one of the biggest culprits in causing metabolic syndrome. Drug interactions, very quickly, there are two types of drug interaction: pharmacodynamic drug interactions and pharmacokinetic interactions. Pharmacodynamic interactions are those interactions in which one medication alters the mechanism of action of a drug at the site of action. And pharmacokinetic interactions are those interactions in which one drug alters the concentration of drug at another drug at the site of action. So they are completely different. Yeah, I told you. So the pharmacokinetic drug interactions based on the pharmacokinetic factors, obviously, right? Which is absorption, metabolism, distribution, elimination. The one we think are most clinically relevant are those which are the drugs which are affecting metabolism of another drug, and they are briefly known as metabolic drug interactions. So it's a very, very easy concept to understand. Metabolic drug interactions in which a drug A alters the activity of enzyme X, right? And enzyme X metabolizes drugs B, C, D, E, and F. Therefore, drug A is going to alter the plasma levels of drugs B, C, D, E, and F. So pretty simple concept, okay? These are some of the enzymes which metabolize these antipsychotic medications. Clozapine is primarily metabolized by 1A2, as you can see, 2+ sign under 1A2. And then olanzapine also by 1A2. Risperidone primarily by 2D6. Quetiapine by 3A4. Ziprasidone actually is metabolized by 3A4, but it also undergoes some secondary phase 2 conjugation elimination. That is why there is only one positive under 3A4, which is a plus for this medication, because it may not be involved with drug interactions as significantly as some of the other antipsychotics, which actually use the CYP enzymes quite extensively. Aripiprazole is metabolized by two enzymes, CYP1A2 and CYP3A4. Paliperidone by 3A4 to a minimal degree, because it's already metabolite of risperidone, right? Iloperidone by 3A4, and asenapine by asenapine goes through glucuronidation, and that is why it is renally eliminated primarily through phase 2 metabolism. Lurasidone, very extensively metabolized by 3A4. What does that mean? That all these enzymes which are metabolizing these drugs, you need to know the list of the substrates for those enzymes, so that when you're giving, let's say, clozapine, what are the substrates for clozapine? I'm sorry, 1A2, because 1A2 is the main enzyme metabolizing clozapine. Look at the substrate for 1A2, for example, here. C under 1A2, cimetidine, Cipro, fluvoxamine, ticlopidine, right? So, for example, let me ask you this. If you give clozapine along with Cipro, what would happen? Both drugs are going to compete for the same enzyme, which will result in increase in plasma level of clozapine, right? So that's the whole concept I wanted you to have, that if you have list of substrates as well as inducers have opposite effect. Tobacco induces the cytochrome 1A2, and that is why it can decrease clozapine levels. Can go each way, right? So inhibitors will increase, or substrates by competitive inhibition can increase clozapine levels, whereas smoking, by increasing the activity of the enzyme, will decrease clozapine levels. So these are the concepts important for you to have. So these lists are extremely helpful if you have in your office. If you have the major metabolic pathway for antipsychotic, and then you have the substrates and the inducers of those enzymes, then you can make sense out of this. Okay. Tolerability, acute and long term. So these are some of the package insert numbers here, just to give you an idea based on the phase 3 clinical trials, which the FDA asks to be done before a drug can be approved, right? So I will just, not everything, but I will focus more on weight gain. Clozapine, 21% of the patients actually reported weight gain. What gain we are talking about? 7% increase or more than 7% increase in weight is referred to weight gain here, okay? So 21% patients reported 7% or more than 7% weight gain. Olanzapine, 29%. And the long-term studies, even 56%. So it's very huge problem there. No long-term studies have assessed with clozapine, so we cannot compare. This is not a head-to-head comparison, but just based on the numbers from olanzapine. Risperidone, 18%, quetiapine, 16 to 25%, and look at Geodon or ziprasidone, one of the lowest here, right? And similarly, if you look at, let's move on, because these are the 4 dopaminergic pathways, which are very important for us to remember in terms of not only neurobiological aspects of schizophrenia, but also what are the bases of adverse effects and efficacy from antipsychotic medication. So I'm sure, we have discussed this, but let me very briefly mention. So there are 4 dopaminergic pathways, which are extending from the ventral tegmental area to different areas of the brain. So one is called mesocortical. I think I discussed this in the last lecture when we were talking about the ventromedial prefrontal cortex and the dorsolateral prefrontal cortex and the mesocortical tract, what implication it has on the mood symptoms and the cognitive symptoms, right? Mesolimbic, so now you know what mesocortical tract is, one of the most important ones. The mesolimbic is the second one, which actually is very important and highly relevant in treatment of psychosis, because when you block dopamine activity in mesolimbic tract, then you can actually decrease the psychotic symptoms. Why that is the case? Because mesolimbic extends from the ventral tegmental area to the nucleus accumbens, and nucleus accumbens is linked with the positive symptoms. Other brain regions are also affected, but that is one of the main region. So where excessive dopamine activity causes psychosis. So that is a desirable effect to have in terms of dopamine blockade, okay? Dopamine type 2 receptor blockade. And then you have nigrostriatal. I think that is something which actually, when you block dopamine activity here, you cause extrapyramidal symptoms. And then tuberoinfundibular is the shortest tract, which extends from the pituitary to the tuberous nucleus in the hypothalamus. And then and if you block dopamine activity in this tract, you can cause hyperprolactinemia or increase in prolactin. Okay, so these four tracts have different implications. Which one is associated? Only one of these tracts is associated with efficacy of antipsychotic medication. All the rest of the remaining three, are associated with side effects or adverse effects. So it's a very important concept to build. Okay. Now, the problem is that, I think it's a very important concept to develop here is that when you give an antipsychotic medication which blocks dopamine activity globally, what is the result? You do get improvement in psychosis, but if you do it excessively, what would you cause? You would cause extrapyramidal symptoms through excessive blockade of dopamine in the nigrostriatal pathway. You are going to exacerbate the negative symptoms. We are going to increase the cognitive deficits by blocking excessively in the mesocortical tract. And tuberoinfundibular, if you block dopamine activity excessively, you will cause hyperprolactinemia. So you see how important it is to know these facts. And this is too complex. I don't have time to go through this, but these are some of the receptor affinities for different receptors for varying between different antipsychotic medications. Okay. So just to give you an example, how I use this list to pick a particular antipsychotic medication for my patients. I use it all the times because it's very helpful to me. So basically, the point I'm trying to make here is that when you look at Haldol, the affinity for D2 receptor on the top left side, right? D2 receptor is 0.7. So lower the number, the higher the affinity. Remember that. So Ki is completely opposite. The higher the Ki, the lesser the affinity. The lower the Ki, the higher the affinity. Okay. So when you look here, remember we were talking about 5:2 D2 ratio in terms of atypicality. Another view of that here. 0.7 for haloperidol. Look at clozapine, 126. There you go. And then when you look at the 5:2A, you see that 16 for clozapine and greater than 10,000 for Haldol. You see how these things make sense, right? So, for example, if you see that the 5:2A receptor is the third on the left side, right? I'm sorry, I was looking at 5:2C, but it's still at 5:2A. If you look at that, 45 for Haldol, clozapine is 16. So it's much higher affinity for 5:2A as compared to D2, 126 versus 16, right? As opposed to Haldol, which is 0.7 versus 45. So that's the definition. That qualifies Haldol as a typical and clozapine as atypical. EPS is a function of D2 receptor occupancy and blockade. The higher the D2 blockade, the higher the EPS. Okay. Always remember this. Hyperprolactinemia, also a D2 mediated, blockade mediated effect. Hyperprolactinemia. Weight gain is basically antihistaminic effects and blockade of the 5:2C, which is another type of serotonin receptors. New onset diabetes mellitus is mediated by H1 5:2C as weight gain is, but also neuropeptides are involved in mediation of diabetes. And there is maybe some role the muscarinic type 3 receptors, but that is questionable. QTC prolongation is mediated by sodium potassium ATPase pump blockade, which results in QTC prolongation. So these are some of the receptor kind of links with the adverse effects. So this is, we just spoke about it for the sake of time. Clozapine, mild and few, as compared to some of the other atypicals, like risperidone is a very potent G2 blocker, is dose related. But even at high, especially at higher dosages, lower dosages, as long as 5:2 blockade is more than G2 blockade, you should be fine. These are the effect on the anticholinergic, the anticholinergic effects. Clozapine is one of the most potent anticholinergic agent among these, the list of antipsychotics shown here. Thioridazine is less than that. Olanzapine also anticholinergic, chlorpromazine, and so forth. Look at Haldol and risperidone, very, very low. So that is why when you pick a medication in dementia patient, where you don't want any drug to have anticholinergic effect, you would like to pick risperidone among the second generation. And that's what I do. Hyperprolactinemia, same story as EPS, because they are both linked with the blockade of the D2 receptors, okay? Again, I just wanted to, yeah. And then the prolactin concentrations, let's skip this. What are the different causes of hyperprolactinemia? So D2 blockade is not the only reason why prolactin is elevated. Estrogen can increase prolactin. Thyroid releasing factor, vasoactive endothelin peptide, VIP, the neuropeptide, opioids, epilepsy, stress can increase prolactin. So there are a lot of physiological stuff too, which can actually increase prolactin. So we have to be really careful in attributing hyperprolactinemia to dopamine type 2 receptor blockade only. And we should actually, before starting, although a lot of people would probably not support that because of the cost involved, it may be a good idea to get a prolactin level at baseline before you start antipsychotic medication. I don't do that, but I use prolactin if I see that my dosages are higher than I need, because prolactin level is a very good surrogate marker for the D2 receptor occupancy. So I use that clinically, actually. It's not 100% accurate, and I don't have time to go over what are the problems, but it helps a lot. What are the effects of hyperprolactinemia? Don't think that hyperprolactinemia only results in preparing the breast for milk and galactorrhea, right? There are a lot of implications. So when you are, the reason I'm telling you this is when you use antipsychotic medication, please be careful about the dosages, because you don't know just by causing hyperprolactinemia what other changes you're producing in a male and especially in a female body, right? What is the effect of hyperprolactinemia? Hypoestrogenism. In addition to amenorrhea and galactorrhea and sexual dysfunction, hypoestrogenism. You know how important estrogen is in maintaining good mental health? It's a natural hormone. Is a natural chemical in our in female women's brains and bodies, which actually protect them, have neuroprotective effect, has some antidepressant effect, even in terms of psychosis. The psychosis has kind of a bimodal incidence in females, and it's less during the times when estrogen is being produced. And perimenopausal periods, psychosis has shown to be increasing because of many other factors may be possible, but estrogen is one of them, okay? What does hypoestrogenism can cause? Sexual dysfunction, medical problems, weight gain, psychological problems, decrease in self-view, decrease in self-worth, cognitive problems, decreased libido, memory problems. In males, erectile dysfunction, ejaculatory dysfunction, gynecomastia, and decrease in libido. clozapine significant, olanzapine significant, risperidone is mild, quetiapine is mild to moderate, ziprasidone modest. So this is something which you can think about. This is a very commonly shown slide, which actually shows you the various level of weight gain in schizophrenia patients over a period of 10 weeks. And you can see that clozapine and olanzapine are the extreme, causing an average of about 4 kilogram weight gain in 10 weeks, as opposed to other medications. And it is kind of a long-term effect. So, over a period of 2.5 years and longer than that, 39 weeks, you see that actually, this is a slide which actually shows that if you cut off at 39 weeks, actually olanzapine showed there's a plateau, right? As opposed to Haldol, which was a control active in this study, active control in this study. But this is just part of that slide. If you look at other slides, which show longer period of time, there is an increasing weight gain with olanzapine. So it depends who is presenting the slide and who has some conflict of interest here. Ziprasidone, very, very minimal weight gain, if any. It is probably weight neutral. That is why sometimes I love to use ziprasidone, especially in patients who actually are already obese, diabetes. Glucose values, as you can see, olanzapine and clozapine, again, the most problematic. After 75 minutes of assessing the glucose, the plasma glucose values after the dose. So you see on the right side, after 75 minutes, you see the increase in glucose levels. Every medication is causing it, but especially clozapine and olanzapine are at the top, right? Diabetic ketoacidosis. I know there's a lot of slides. I would leave some time for questions. I know I've just touched the tip of the iceberg here, but it's not doing justice having one lecture on antipsychotic medication anyway. Okay, I have to go fast, and it just doesn't kind of help the audience. Yeah. Okay. So, are there any questions?
There are none in the chat box, but if any participant would like to unmute their mic and ask directly, they're more than welcome to do so.
Okay, then. Okay, then next time we'll talk about some of the partial agonists and along with some of the new concepts. Okay. Is that okay?
Sir. Thank you, sir.
Okay.
Yes, sir.
Thank you so much.
Thank you, sir. Your lecture has been very thorough and very comprehensive. I'm sure most of us.
It was actually not comprehensive, but thank you for your kind compliments, because there's a lot more to present. Okay.
Yes, sir.
Thank you. Everybody has a good rest of the day. Okay. Bye-bye.
Thank you. Thank you for joining, everyone.
Yeah.
Meet